I'm Dr. Monty Pal from City of Hope, and this is On the Edge of Breakthrough, Voices of Cancer Research. Each episode, we bring you the minds behind the science, the stories behind the data, and the breakthroughs that could change everything. Let's dive in. Welcome, everyone, to On the Edge of Breakthrough. I'm your host, Monty Pal, and I'm a medical oncologist here at City of Hope. I'm delighted to introduce Dr. Enrique Montero, who's a research professor in the Arthur Riggs Diabetes and Metabolism Department here at City of Hope. Enrique, welcome to the program today.
Thank you.
You know, it's just remarkable to me. You've been here at City of Hope for 10 years. I've been here for about 20 or so. And, as I think about, everything that you've accomplished career-wise, I see so many places where perhaps our careers may sort of segue in the future. And we're going to get to that in just a moment. But I was actually really quite enthralled by your training. So were you born and brought up in Cuba, I take it?
Yes.
And you did your early education there through PhD work as well?
Yeah, I was born in Cuba, and I finished my MD degree also in Cuba with a specialty in clinical immunology. And then I moved into more in the basic research. And the idea or the concept behind was to develop novel immune therapies for cancer and autoimmunity. And that was the basis of my PhD program.
And we're definitely going to come to that in just a second. I'm just curious, when I was in medical school, the choices that you typically think of are, family medicine or pediatrics or general surgery or what have you, right? I mean, it takes a certain type of individual or maybe experience or something you encountered with a patient to drive you into the field of immunology. What was it in your case?
So I think that my very first patient in the medical school was at the third year. She was a very young patient that she developed or started with symptoms and signs that affected multiple parts of the body. At the end, the diagnosis was lupus, and a very difficult disease to treat. She passed away in 6 months, and that was probably the most difficult time for me when I was in my medical school, and then I decided probably I have to do something else.
I have to tell you, I remember in medical school as well, very vividly treating patients with lupus, and it's just the most challenging thing, right? I mean, in many ways, it was also the state of many fields in oncology at the time. We had no good treatments. You might try steroids, you might try immunosuppressives, right? But no good way to treat the disease. So I definitely see where you're coming from and how that might sort of steer you towards novel avenues for therapy, right? Beyond the training that you had in immunology in Cuba, you actually have just this amazing sort of world tour, I'll call it, of different places that you've been. You've been to the Weizmann in Israel, you've been to Portugal, you've been to Zurich, Switzerland for your training. Tell me how those opportunities came about, and maybe just give me a little tidbit about what you learned at each one of those places.
I've been trying to work in between two fields, let's say cancer and autoimmunity. And also trying to work in between two different areas, basic science and clinical application. I had the chance to go to Switzerland to work with Franco Cavalli and just in clinical trials for novel immune therapies, just to learn how to do translational science.
What sorts of treatments was he looking at that point in time?
At the time was to learn how to try or how to evaluate patients in that particular case with cancer, receiving novel drugs. How to try or how to evaluate first in human studies.
Got it.
How to check toxicity, how to check to get some flavor of the potential therapeutic effect. How we can understand the doses that we probably have to escalate during the trial. I think at that time I was mainly involved in some of the growth factors that now are very well applied in cancer. And that was a phenomenal experience, learning how after moving in the development part or the discovery first, development, and then how we can do the transition into first in human study, first time that you inject a drug. So that's the experience in Switzerland. And I think that immediately afterwards, I moved to Pasteur Institute in France, where I moved more. It was a big shift because it was from seeing patients every day, receiving new drugs, to a lab with Antonio Coutinho, that is one of the leaders in the field of autoimmunity, immune regulation, and to do some basic science with him to understand how the immune tolerance happens, how the body or how the immune system can control the overreaction against your own tissues. And I think that working with him, he's I will say that sort of a outlier in the field. Tolerance has been considered as a lack of autoreactive cells in one individual. And the interpretation is if you don't have these self-reactive immune cells, you will not have autoimmunity. And he was probably pioneering the idea that the immune system is beyond that observation, that we may still carry some self-reactive immune cells, and still the body is able to control or modulate that response. And rather than being dangerous, probably these self-reactive cells are convenient to prevent the development of tumors. I think that was the phenomenal experience I got with Antonio, and as part of the continuation of that story was why I moved to the Weizmann Institute with Aaron Cohen, who was I would say that this is the one of the most brilliant minds in immunology, and he has probably a not so popular concept that is called immunological homunculus, so that we have in the immune response and immune repertoire, we have different antibodies or cells that are able to recognize every part of the body.
Okay.
So the immune system is a sort of a communication system, the way that probably we are communicating today. But and the function is to maintain the homeostasis of the body, not only to prevent or to control infections, but mainly has a physiological process of healing what is wrong and preventing the emergence of tumors. Mm-hmm. So that's I think that was probably the blocks that just made part of my initiation in this field.
I think that makes a lot of sense. So you had sort of the clinical phase 1 experience in Switzerland. You had the experience of, getting deep in the lab at the Pasteur Institute, at the Weizmann. City of Hope, incidentally, has a lot of collaborations with the Weizmann that are still ongoing. It's a really well-established bridge that we have to Israel, in fact. I think that is a good segue into maybe discussing some of these really pioneering discoveries that you've made. And just for the audience here, we're going to talk about a molecule called CD6. And if you look at white blood cells in general, these are sort of coded with various markers. They're given these terms CD1, CD2, CD3, and so on. But you've really helped us understand what CD6 is doing at the surface of the white blood cell in particular. Maybe you could elaborate on that for our audience a bit.
I mean, it's just a way to, it's a short way to say that something is a molecule is expressed on the cells. And even if we don't know what is this one, we are given we are tagging this with a name.
And tell us what CD6 does. When CD6 is at the surface of the T cell, what's its function?
That particular marker is expressed mainly on T cells. Let's say T lymphocytes. Those are involved with so we have a sort of a classical division in immunology. That is, we have antibodies or we have T cells doing the process of helping the body in controlling or inflammations or infections or whatever. And so the CD6 in particular is expressed mainly on T cells, and is a molecule that is usually has fluctuations once the cells are, let's say, in the normal state, or they are overactivated. If the cells are overactivated, you will have more CD6 expressed on the cells.
Okay.
And this, and in particular, when the cells are overexpressing the CD6, this overexpression is linked or is associated with the capacity of the cells to be more inflammatory. So let's say inflammation is linked to the overexpression of the CD6 molecules and T cells. And that's exactly that this pharmacological difference is what brings us to the opportunity to say, okay, why don't we try to modulate those cells overexpressing CD6?
So this is a very logical continuum. You've just explained to us that CD6 coded T cells are really responsible for inflammation, right? And so perhaps a technique or technology that could mitigate CD6 T cell activity could potentially help with diseases where inflammation is a problem, right?
Absolutely.
And talk us through this, because I guess there's a couple of different clinical states that City of Hope focuses on where this would be applicable. One big one, and this reflects the department that you're in, is diabetes, right? So, we always think of particularly type 1 diabetes as being autoimmune in nature, maybe driven by some of that inflammation. Tell us about the application of these CD6 technologies there.
Our perception or our hypothesis behind after this finding that the CD6 overexpression is linked to inflammation is how we can target this molecule instead of let's say if we have what we probably is very popular now, these monoclonal antibodies that they can is a molecule, a small molecule is only 150 kilodaltons that we can use. It's like any regular antibody that we develop against vaccine or against any infection, but we produce in the lab. So how we can benefit from using the technology of antibodies to target the CD6 molecule and to try to modulate the cells that carry the overexpression of that molecule. So the principle behind, and this is a clear difference with our the previous work in this area. So the previous perception was that if you target the cells associated with inflammation, if you kill the autoreactive cells, you will control the problem. But there are some observations that probably do not match with this hypothesis, because after killing the overreactive T cells in some other studies has been found that you have to continue the treatment for a very long time. Mm-hmm. Otherwise, when you stop the treatment, the cells will regrowth again in your body, and the autoimmune process will continue. The inflammation will continue.
Sure. And that's tough for a disease like type 1 diabetes, right? Because, you're going to be on a lifetime of treatment. Most people, when they're diagnosed, are, teenagers, right? Relatively young. And so I see what you're saying. If you want to target CD6, right, in a disease like type 1 diabetes, and if you want to use an antibody, a single drug, you're going to have to be using that, for eons. And of course, that leads to the issues of cumulative toxicity, cost, et cetera. So tell us how we can sort of circumvent that.
I think that, the second, just to also put in the context of this idea, is we consider that probably killing the cells, the inflammatory cells, will not do, all the benefit that we are expecting for a long run. So what we consider was that targeting CD6, probably we can re-educate the immune system. So we will not kill the cells. Okay. So we'll modulate the cells in the way that they will stop being overreacting against the self tissues. They will just rewire the internal interactions to behave like a non-inflammatory cell. So in that way, so we are re-educating what was going wrong in these patients with type 1 diabetes.
And tell us how you're doing that. Is that with a different type of technology?
Yes. Now, so there are like two options. So we have the option of the antibody. We already have developed an antibody that is specific for the CD6 molecule. This antibody has been efficient in other indications, modulating the inflammatory cells in other indications like psoriasis and rheumatoid arthritis. But type 1 diabetes is like probably is a higher bar. So it's knowing that multiple attempts they have failed in modulating the process. So the technology that we apply here is something novel. I think that it's based on the old experience that City of Hope has developing CAR T cells for cancer. But in that case, CAR T cells meaning that we have a T lymphocyte that has, we insert, let's say, to simplify the idea, with a sort of an antibody that will give the specificity for a particular a molecule or CD that is expressed in a tumor, and then we enhance the inflammation of these inflammatory capabilities of the regular T cells to act against tumor. In our case, what we did was the reverse of the story. So now I'm coming back to the cancer and autoimmunity connection.
Well, and I'm glad you brought it up this way, because we had Dr. Foreman on, Stephen Foreman, a couple of weeks ago. And so we were talking through the program here in CAR T-cell therapies. And I think our unilateral focus was really on how we use CAR T cells for cancer. And that's a very different application from what you and I are talking about, right? Because there we're really trying to sort of hit on a foreign entity, if you will, right, within the body. Here, the goal is to not necessarily get rid of an invader, so to speak, right, i.e. cancer. We're really trying to sort of regulate the body's own tissues, right?
So, yep. So it's regulate and also regenerate the tissue. So that's something that probably is not, because, in principle, you can control a disease, but if you have, like in diabetes, you have a tissue that is already not only invade or is all these inflammatory cells are going inside the tissue and start destroying the tissue, you have to control that process. You have to control those cells. But at the same time, after controlling the cells, you have to facilitate the regeneration of the tissue.
Right.
And that's exactly what we are trying to do here. So instead of using the T effector cells associated with the inflammation, so what we are using in our technology are T lymphocytes that we call having a regulatory function. So this is a subgroup of lymphocytes. It's only around 10% of our army of T cells, and they are able to regulate the inflammation. So those cells, in principle, they have the responsibility to keep the response on check. So they prevent the overreaction against your tissue. Sometimes fails, and sometimes you don't have enough number of cells to do that. So what we are doing in our case with our technology is we are taking from patients, taking out from the body these regulatory cells, even in tiny numbers. Then we put them ex vivo in culture, and we modify genetically these cells with the specificity of the CD6 antibody that we developed earlier. Mm-hmm. And then we expand them at the end. What are we expecting to have? We are expecting to have these regulatory cells that by default, they have that functionality to control the immune response. Once we take them outside and we give them all the nutrients or the growth factors required for them to reinvigorate, to regrow, to reacquire all the capabilities needed for their function. At the same time, with the genetic modification, with the fraction of the antibody, we are giving these cells an extra capacity. So they are regulatory. We know that the CD6 antibody that we developed before is also a regulatory molecule. We put these two together. So we are just arming the Tregs with an additional capacity to go, to recognize the inflammatory cells through the antibody that we inserted genetically. And at the same time, so the cells are migrating to the inflammation site. In this case, we are expecting they go to the pancreas. Mm-hmm. And in that place, the dual function of the antibody plus the regulatory cells, we are expecting that we'll be able to modulate the the immune response, control the inflammatory cells, and also regenerate the tissue in this patient.
That's so interesting. So tell me how it's working out in clinical practice. Is this something that right now is in clinical trials in type 1 diabetes?
The initial trial we have, because this one is a typical first in human study. City Hope has been the first in many fields. I think it has been also the first in the field of CAR Tregs. This is a new acquisition. So City Hope, we got probably the first authorization from the FDA to perform a clinical trial using a CAR Treg. And because it was the first in human study, we were required to do in patients with, let's say, more, that patients that they have less option than an individual with, other indications like diabetes or psoriasis or things like that.
And that makes sense, because I think that, if you've got this high risk, high reward technology, right, you may not want to use it in a setting initially, like type 1 diabetes, where you do have the option of the patient going on to, chronic insulin therapy and so forth, or psoriasis, where there's the, anti-TNF agents and so forth. So I think what you're saying makes a lot of sense. So what indication did you settle on then after talking to the FDA?
Yes, also built on top of the capabilities developed at City Hope. So we know that this is City Hope is also a leading institution in bone marrow transplantation.
Yeah.
And one of the consequences of bone marrow transplantation is that patients may develop a reaction of the transplanted cells against the recipient, against the individual who received the marrow. So in that case, this disease that is called graft-versus-host disease was the indication that we started. So we wanted to control the reactivity of the transplanted cells against the body of the recipient individual.
Okay.
And that was the first trial that was approved by the FDA.
This is great, because graft-versus-host disease is something that I haven't treated since I was in fellowship, but I just remember how daunting it was. You envision the patient who has leukemia, right, or perhaps lymphoma, and they undergo what's called an allogeneic transplant, where they're getting stem cells or bone marrow from another individual. They're very immunosuppressed, for an extended period of time, so they're already prone to lots of infections. And then that graft that they get, which is intended to fight off any existing cancer, can start reacting against their own organs, right? So you can end up with really severe and critical diarrhea. You can end up with really horrific skin changes. These are really pressing problems. So I applaud you for coming up with a good strategy for us to kind of try to mitigate graft-versus-host disease.
Yes, and if we check, if we compare, I think that the GVHD is a very close disease in terms of the expression to lupus, because you have multiple organs affected, as you.
Oh, that actually makes sense. Yeah, indeed.
Yeah. So then we have, and that's also part of the limitation of the current therapies for chronic GVHD, because you have skin damage, you have even a damage in the oral damage, or in the eyes, or the livers, or you have multiple organs affected.
And ironically, you're just layering on more and more steroids in most cases, right? To try to immunosuppress patients, or cyclosporin. And, just for context for folks in the audience, if you end up using all of these immunosuppressive drugs, that risk of fatal infections goes up manyfold. So, it really belies why we might want a technology like this.
Yes. And probably an additional value of our strategy. So let's say that the CAR Tregs, they have not been, has been also, part of the strategy of other institutions, and other, even the new companies are emerging just to work in the field of CAR Tregs. And the strategy has been using these regulatory cells, specific for one particular CD or molecule in a particular organ. Okay. Let's say if it is diabetes, to have a CAR that is specific for insulin, for GAD, or for another antigen expression in type 1 diabetes. The problem in GVHD, if we follow the same strategy, is that because you have multiple organs affected, so you may need multiple CAR Tregs. So one that is specific for a CD that is expressed in the skin.
Okay.
One that is expressed in the liver. One is that is expressed in the eyes. And then in that case, it's complicated in terms of technology.
Right.
And also it's complicated in terms of the pharmacoeconomics of the application.
Now, is yours different? Is it one? Tell me how.
In our case, what we instead of going after or using a CAR that is specific for one particular organ, we use the CAR that is specific for CD6 that is specific for T cells, inflammatory cells, and then we go directly to the cell that is causing the disease. It's not to the organ. So we are directly regulating the inflammatory cells.
Okay. Oh, wow.
And then, in that case, we don't need multiple CAR Tregs because it's a T-cell mediated disease. Mm-hmm. So then we can regulate the inflammation in every organ, targeting the cell that is causing the problem.
Got it. Okay. That makes sense.
And that's the reason why GVHD is the perfect initial indication for our novel strategy.
Now, are you able to share with us any of the early insights that you have from the clinical trial? I don't want you to, break any barriers of confidentiality. And by the way, little birdie told me that you've actually got an oral presentation at ASH for the data. Is that right?
That's true.
Okay.
So I think, that we received the approval, about 2 years ago from the FDA. And then we started the trial in GVHD. 6 patients have been treated so far. I think we have a phenomenal team, both my group doing the basic science with our collaborators like Steve Foreman and Christine Brown and Jamie Warner in the area of manufacturing of this cell therapy, and also part of the discovery. And we have the clinical team with Amaddeep Salhotra and Ryo Nakamura.
I'll just mention for our audience too, Ryo Nakamura is a very dear friend, and he and I have actually collaborated on some different strategies to mitigate GVHD, and in my case to really sort of do the opposite, maybe augment immunotherapy using probiotic strategies. And so we've worked together there, but I had no idea that he was actually involved in this space. He's very passionate about trying to find new strategies for GVHD.
Yes, he's amazing. He has been searching for any option, any novel approach that can help his patients. And I think that's the reason why we just connected quickly with this opportunity. And then, so the trial is ongoing now with the first 6 patients. We have to say that, because this one is a first in human study. The initial objective was to check safety and feasibility of this new approach, and for that we have to start with a very, very low doses of the therapy that we are developing, and we were not expecting to see any therapeutic efficacy or signs of improvement in these heavily treated patients. So imagine that the initial patients are accepted for the study. Are usually those that have already failed for the previous available therapies.
Oh yeah.
Or even the combination of those therapies.
Right.
And this is the group of patients that we have already dosed with this novel therapy. So the first patient has already passed the first year after infusion.
Oh, that's amazing. Okay. Good.
And the first observation we have is that this novel approach is safe.
Okay.
We have not seen any sign of severe toxicity or damage in the body of this individual.
Did that patient's GVHD get better in due time, or? So
in this patient, the first observation. So let's say, one of the individuals, a very young individual, with this chronic GVHD. A lot of limitations in terms of physical activity, and then this patient received before he was receiving up to 6 different therapies, and he was not able to control the disease. After injecting with our approach, of course, for the trial, we have to stop the previous treatments or the ongoing therapies. So we have to use only this one, plus something that is, a basic therapy for GVHD, but it's not. I mean, we know that doesn't work in this individual, but still, it's recommended to keep a low dose of that medication. So in this individual has been stable first, and then start after a few months, and now comes to the idea of why we would like to think on, in reverse for any new drug. We want to have a long-term effect. So this patient start with a disease stabilization, and then start with a responding, meaning that the patient start just reducing the
symptoms got better, right? Symptoms,
yes.
Okay.
And now, has been still today has a partial response.
Okay.
But with this tiny dose, and we cannot change that. The 2 additional observation is that this patient first has not required to go back into the previous therapies. So he's stable without any additional drug, and was injected sort of 1 year ago.
Right. That's great. Well, that's really interesting. Good.
And the other thing that is quite surprising is that the functional activity of this individual, the capacity to live his regular life,
right,
has increased. Substantially. He's doing more activities.
Oh, well, that's a nice way to sort of segue into, perhaps this ASH presentation. So we're excited for you to present your data at ASH this year. For the audience, ASH is the American Society of Hematology, and it's really kind of the premier organization to present data around, drug therapies and novel approaches just like this. So I can imagine this is going to be one of the spotlighted presentations there. Congratulations.
Thank you. I think they have an excellent motivation, but not only to continue with this trial. Now we are in the second dose level that
right,
we are expecting to increase even the response. We receive also an authorization from the regulatory agency to reinfuse these individuals. That will help consolidate the clinical effect. But I think that what is in mind of our team, particularly the clinical team, is that we are building the opportunity to expand the use of this novel approach into other indications like type 1 diabetes.
Wonderful. Well, that's super exciting. And we're going to have you back in coming years to tell us where this particular technology sits. It seems like it's going to advance quite far along. I was just curious, getting back to what we started with, which is this, really sort of amazing, and I'll say, sort of semi-circuitous trajectory that you've taken in your career. Part of what you've done ahead of coming to City of Hope is you've worked in industry. You were in La Jolla on faculty for a period of time. I always love to get to know what sort of drew people to the institution. I personally am a little bit boring. I grew up a couple of miles away from here. So, I've been wanting to come to City of Hope ever since I was a child, perhaps. But tell me about yourself. What ultimately brought you to City of Hope as opposed to other opportunities?
I think it's quite simple, quite straightforward. So then, working in for example, La Jolla Institute. La Jolla Institute for Immunology is like probably the one of the best institutions for in this field, in the field of immunology, and it's mainly focused in basic science. But the translational component is quite limited, and requires the association with other, hospitals or clinical institutions. City of Hope is like the place where you have everything, at once. So you have here, the lab for basic science. You have manufacturing facilities. You have a culture of quality control and interaction with the regulatory agencies. And you have a robust and phenomenal clinical group that will help in the process of translation of the discoveries in the lab till patients. And that was actually the reason why City Hub. City Hub is the place where we can close the cycle. So we can go from the basic science till the clinical application, learn from the trials, from the outcome of the trial, and then to develop the second wave of science or the novel drugs. And that's exactly where we are right now.
I have to agree with you. I've had the same experience kind of working in the microbiome space and seeing, compounds really sort of come from, more or less the laboratory into patients, into phase 1, then phase 2, now phase 3 trials. I mean, it's just remarkable what you're able to do when you have everybody on site. I was actually at our microbiome symposium yesterday, which was held by Rob Jank, who just came over to run one of our microbiome core facilities. Terrific guy who hails from MD Anderson previously. He had a bunch of investigators there from other institutions, which shall remain nameless, but they're in the southwestern U.S., and they all said the same thing. They sort of wish they had that close proximity between the basic scientist, the translational scientist, and the clinician, just to sort of complete the loop, if you will, as you said. So that makes a lot of sense. We always sort of close out the program by asking our guests a very difficult question, but I'm going to throw it at you anyways. And the question is, the title of this podcast is On the Edge of Breakthrough, Voices of Cancer Research. What does On the Edge of Breakthrough mean to you?
I think it's just trying something that is not obvious.
Brilliant.
Something that is that goes beyond the common sense, what is called the common sense, and aiming just to change or help patients to change the expectation they have now with suffering any particular disease. How we can bring back to a normal life this individual. It's not only the dream of controlling a disease. It's not only the dream to regenerate the tissue. It's just to heal also the mental status that patients could be patients at some point, but they can go back into the regular lifestyle after an innovative therapy is used in this individual.
Brilliant. I love that. Very simple answer, just going beyond the obvious, but it's so true. You basically have taken, this CAR T-cell technology that we at City of Hope have been talking for years about to fight cancer and sort of, repurposed it in a different way. Again, with CAR Tregs, very, very different construct. But now you're actually fighting autoimmune disease, right? It's a brilliant manifestation of what you just said there, I think. Well, Enrique, it was a real delight to have you on the program. And again, I hope to have you back in coming years to really kind of give us a sense of where this technology has advanced.
Thank you for the invitation again and ASH presentation. We had this work already moving in GVHD. Now we want to go in type 1 diabetes. We want to help patients with type 1 diabetes. And then what else? We want to go beyond, not only to have a drug that may help these patients initially, but also to cure them. And that's the dream that I'm sharing with my colleagues, and that's our dream. And when you have a collective dream, probably things will come to reality at some point.
Indeed. Well said. Well, pleasure to have you.
Thank you.
Thanks for tuning in to On the Edge of Breakthrough. See you next time for more insights from the front lines of cancer research and care.